clinical pharmacist in the mental health. So we are eagerly waiting for his talk, and the floor is yours. Thank you. So, dear Matej, we cannot hear you. I think you are muted. Can you hear him? Dear Reina, can you hear him?
Yeah, no, I can't hear you. So hang on. So you're not mute. You switch off your own. I think usually Matej has 4 computers, and it's at least one who doesn't work today. So we see your screen, but we can't hear you.
Now you hear me?
Yeah.
Okay. So, my dear colleagues, ladies and gentlemen, I'm very happy to be here. My today's talk will be about clinical pharmacists in mental health. So I will go through the evidence and the practical cases. I have some conflict of interest, but not according to this lecture. And I presented some of my pictures from my different workplaces, like, for example, psychiatric hospital, like primary care setting, and my university setting. So next to my university's teaching, I'm also clinical pharmacist in the real clinical practice. So I work almost daily with the patient with the mental health problems and the patient in primary care center, which usually have many mental health problems. And here is my outline. First, I will talk about introduction. Then I will introduce you ambulatory clinical pharmacy service in mental health. Then I will introduce to you hospital clinical pharmacy service in mental health, and of course, summary and recommendations. First, something about the problems and identifications. We know that the mental health disorders represent one of the top 10 causes of disease burden worldwide. And what is the problem? Especially total polypharmacy is a frequent problem in this population, as already reported by Florian. And although effective pharmacological and non-pharmacological treatments are available, more than 75% of people, especially in the low and the middle income countries, receive no treatment. And if we are moving a little bit to neurology, so we are on the border with neurology, we know that patients with dementia, they are usually, some of them, they are over-treated, and approximately 60% of them, they have 7 or more medications at the same time. And what is the problem? Problem is that the most patients with the mental health disorders, actually particularly elderly patients, are not represented in typical randomized controlled trials, which is the problem because of the evidence. And still many patients are not treated as they should be treated, especially in primary care. According to the huge study published by Professor Kessler in JAMA 15 years ago, he found that only 25% of patients with depression were being treated as they should be treated. And what problems we have been with medications? There is a huge problem with treatment guidelines adherence. According to the Dutch study, and the same results were found in Slovenian study and the US studies, that only approximately 30% of patients in primary care with anxiety disorders and depressions were treated according to the guidelines. And there's another problem. There's a high effect of placebo in psychopharmacological trials, especially in the children and adolescents. And that's why we have more or less positive studies of fluoxetine, and the other antidepressants were more or less negative. And what next? There is a problem with the adherence in the patient with schizophrenia. And the last point, the clozapine is used very late in many countries. According to some studies, approximately 2 years later as should be used. And now, what is with polypharmacy and potentially inappropriate medications in elderly patients with the mental health problems? We know that probability of interactions increase with the number of medications, and excessive polypharmacy result in a higher risk of PIM administrations. Approximately 50% of the patients in nursing home settings with Alzheimer's disease receive at least one PIM. And polypharmacy may be related to the functional decline. And interesting that the most of those real patients are not covering in the existing treatment guidelines and the meta-analysis. And that's why we should move from the real evidence data to the more practical data. I would like to say real clinical psychopharmacological studies and trials to combine them with the evidence trials to improve our practice. And if we go a little bit further, it is one very huge, interesting cross-sectional study which was published approximately 10 years ago in Austrian Medical Journal. And the researchers included more or less all nursing home settings in Vorarlberg region in Austria, and they checked the number of PIMs in different patients. And what was very interesting that most of the PIMs were associated with psychotropics, especially protipendyl, lorazepam, then, for example, flunitrazepam, haloperidol, nitrazepam, and so on. And it is very clear that those medications, which are not recommended in the elderly patients even, are used very, very frequent in real clinical settings. So still we have a space and still there is a gap. And that's why we should teach real clinical psychopharmacology. Very similar situation was shown in inpatient settings, where approximately 50% of patients were being treated with at least one PIM. And what's next? Here's my case from my nursing home ambulatory setting. So one of the patients, John, 82 years old, he had many problems like dementia, overactive bladder, neuropathic pain, depressive symptoms, and restlessness. And here's the medication list. And patient was treated with amitriptyline, simvastatin, esomeprazole, quetiapine, duloxetine, trospium, ciprofloxacin was added 3 days ago because of urinary tract infection, and memantine was also added. So we have many real questions. For example, which medication is the best for depression? Which is the best for the overactive bladder? Which is the best for pain? So what to do with quetiapine is good medication for the elderly patients, often used in many European countries, but the evidence for its use is very poor. And there another story with what to do with constipation. So this is a real case. For example, medication for depression, there is very clear, there is one contraindication between duloxetine and ciprofloxacin. So it's better to avoid always if it's possible. So one side of the table would be to switch ciprofloxacin to another medication for urinary tract infection, like, for example, some penicillin medication or even nitrofurantoin. And another question, many medications for overactive bladder, they can produce delirium and restlessness in the elderly patients. And that's why it's very necessary to avoid trospium if it's possible, because it penetrates to the central nervous system and can produce delirium and some other problems. And there's another problem with amitriptyline. Tricyclics are not recommended in the elderly patients because they can produce anticholinergic effects and even can worsen constipation and so on. So it is a very interesting case and similar cases we have in clinical practice. And that's why we should combine real clinical psychopharmacological science and knowledge, not just based on the guidelines, which usually consist only from the randomized trial with one patient and one medication. And what clinical pharmacy can help? First of all, I know that in some countries, clinical pharmacy is very well developed, like, for example, in UK, especially in Scotland, in the last 10 or 15 years, where clinical pharmacists are part of the team in the primary care settings and hospitals. And very similar situation is in my country, in Slovenia, in the last 10 years, I would like to say. And we have different type of collaborations where, for example, clinical pharmacists provides medication review via referral paper by, for example, GP or psychiatrist, or we have even some advanced practices like in UK, where clinical pharmacists also can prescribe some medications, like, for example, antidepressants in primary care. And what is the situation about ambulatory clinical pharmacy services in mental health? We have developed in Slovenia in all primary care settings, because we are very small, we have 2 million inhabitants, we have only approximately 20 hospitals and 6 hospitals for the mental health patients. So we can do pilot trials very easily and the national studies. And in primary care, we establish clinical pharmacy settings within each primary care center. And most of the issues are associated with psychotropics, because usually the GPs, they refer patients to us because of different problems, but the most of them, approximately half of the problems, are associated with the mental health issues. And what we do, we provide medication review, we identify medication-related problems in the patient in conversation with the patient, and then we provide medication review, which goes to the GP or psychiatrist, and then the final decision is on them. We can also monitor the patient, for example, to have another referral if we have any important question according to some medications and changes and so on. And here's, for example, Slovenia, why we establish clinical pharmacy primary care settings, and the most of the issues are associated with the mental health problems, because we have very, very low number of GPs. For example, like Poland, Greece, Bulgaria, Sweden, Slovenia, and Hungary, according to the number of general medical practitioners per capita or per 100,000 inhabitants, we are on the bottom line, and that's why we should help them. So the primary care in Slovenia works in primary care settings, and usually we have 10 GPs and 1 psychiatrist, 1 dermatologist, 1 dentist, and 1 pharmacy in 1 primary care complex. And also we have primary care clinical pharmacists now. So we have like 60 primary care settings in Slovenia, and we are covering also nursing home settings. So this is also important, because nursing homes within the same region, they are covering with the same GPs like in primary care settings. So we also go to the nursing home settings. We have 26 hospitals in Slovenia, and just 6 hospitals are special mental health hospitals. And also we are working in the GP's offices. We have everything like the data sets, like the lab test. We can do measurements. And so it's very usual way. We have patient inside, so we start conversation with the patient to ask some important questions about medications, to check the drug-drug interactions, to check the doses, and then we provide a review. And patients can find us very easily on the web pages of primary care settings. So I'm working, for example, each Wednesday in afternoon, how they can come to me with a referral paper. It's very easy. So we are working in the same settings like GPs, and we have a waiting clients like 1 to 2 weeks usually. And here is Slovenia. Here's a map Slovenia. Slovenia has a shape like a chicken, and in the middle of the chicken is Ljubljana, which is the biggest Slovenian city with 300,000 inhabitants. We have only 2 million, so it's population more or less like, for example, Birmingham or Manchester in the UK. And here is a map of the primary care settings. With the blue squares are those primary care settings where we already have clinical pharmacy settings, and the red we don't have. So approximately 85% of Slovenia primary care settings we are covering, which is very fine, because we can help GPs in primary care settings and also psychiatrists who are also working in the primary care in Slovenia. And now I will go through some studies. This was first study published in Scientific Reports in 2019. It was prospective, non-randomized study in which we included 24 patients which were eligible to provide or to fill a questionnaire, because we studied an impact of clinical pharmacy medication review on the quality of life and different outcomes like total number of medications and total number of drug-drug interactions and the total number of PINs. And after 2 months, we checked the consequences. And the acceptance rate was approximately 60% from GPs and psychiatrists of our recommendations. And very, very important that the total number of medications decreased for 20%. We included nursing home patients treated with the excessive polypharmacy, which is usually our population which we have in the primary care settings. And the number of DDIs dropped significantly, and the quality of life improved significantly. So it's a very important result, which means that our business has an impact on the humanistic outcomes, such as quality of life. And now, what's next? Also, the number of PIMS dropped significantly, but what we observed that half of the patients were treated with benzos and antipsychotics even more without an improved indication for many years. So this is one very important question, how we will deal with this population in the near future in Europe, or maybe at the general level. So what we will do with the antipsychotics, because it's very clear that if patients are treated for behavioral problems of dementia, after 6 months, if they are switched to placebo or they are continued to antipsychotics, there's a higher mortality rate in the patients who continue with antipsychotics. So this is also one very important clinical point of view. And as a clinical pharmacist, we can also help to solve those issues. And another study was also done in primary care setting. This was in my primary care setting in Eastern Slovenia, where we checked the consequences of medication review in primary care settings provided by the clinical pharmacist in a 6 months level. And very important that 99 recommendations, which were accepted by the GPs and psychiatrists, were still maintained 6 months after the interventions had been proposed. So we included only patients with the mental health problems in the study, in the retrospective study, and we included patients with the polypharmacy. So it means patients with 5 or more medications at the same time, and elderly patients, so the geriatric patients. And very important, the number of PIMS reduced significantly, especially the number of benzos, like for example, diazepam reduced for 50%, zolpidem, alprazolam, haloperidol, flurazepam, and so on. And the total number of medications also reduced for approximately 50% at the end of the study. So it means that it's very huge approach. If we work together, I would like to say it's very huge and strong deprescribing tool in real clinical practice. And we check also an impact on the treatment guidelines adherence before and after. And after our medication review, the treatment guidelines adherences improved significantly in patients with depression for 40%. Many of them, they were treated still with benzos as a long-term treatment together with antidepressants. So we recommended to discontinue with benzos and continue just with antidepressant medication, or to add maybe some valeriana or some herbal medical product instead of benzos, which sometimes work in a clinical practice. The same story was with anxiety, insomnia, and schizophrenia. The number of patients who were treated with antipsychotic polypharmacy and elderly patient antipsychotic polypharmacy was still very high. And after our recommendations, this number dropped significantly. And in the third study was published in Scientific Report last year, so it's a very new study. We included 3 different Slovenian primary care settings and only patients, psychogeriatric patients, so over 65 years, and patients who were being treated with 5 or more medications at the same time. So it was also a retrospective study, and we checked the consequences of medication review in this study. And on the right picture, this is very clear again that the number of PIMS dropped significantly, especially the number of patients who were being treated with the benzos, diazepam, zolpidem, for example, alprazolam, nifedipine, lorazepam, and so on. It means that collaboration with the clinical pharmacists in the primary care is a very strong deprescribing tool in the real clinical practice. And the number of medication dropped significantly because we observed that the patients were being treated with some medications without indication for the many years. And nobody actually didn't stop them. And the patient took them. So it's very important to make a review and to collaborate, and then together we can make better. And also, we checked that the treatment guidelines adherence for antidepressant and antipsychotics improved significantly. And what next? In the UK, they have a pharmacist prescribers like 20 years in the 2026. So all pharmacists who will finish the master degree study will be independent prescriber. What it means? It means that together with the physicians, we establish a formal relationship, and then we delegate patient care functions, and then we monitor patients, and together we can improve outcomes. This type of collaboration is also very famous in the United States, where usually physician delegates some task to the clinical pharmacist and write the task within an agreement. And so clinical pharmacists can monitor the patient within the agreement and can also prescribe some medications or to titrate some medications and so on. So this is known as a depending prescriber clinical pharmacist, which is known in the United States like for 20 years. And the studies are very positive, as you will see very, very soon. We have also pharmacists prescribed in the New Zealand now for like 7 years in the primary care settings, and collaboration is very good. First, they started with some 10 or to 20 medications. Now, after 5 years, they can prescribe the same amount of medications as the GPs can prescribe in primary care settings, also antidepressants. And now we have some studies done in the United States in which were described collaboration care with clinical pharmacists, and they included patients with depression, and they monitor the patients after 6 months. So they randomize first patients to the clinical pharmacist or to the usual care, and after 6 months, they got very positive result in the terms of medication adherence, and also in some studies, treatment guidelines. I would say the outcomes improve significantly. They use some different scale, like the Beck depression scale and so on. And the similar studies have been done in Scotland with clinical pharmacist independent prescriber, and they also found that if the patients were randomized to clinical pharmacists in primary care, I would like to say depressed patient and a patient with anxiety disorder without very, very complicated comorbidities, so the patient in the primary care, and there are also very positive results after 6 months of treatment on the treatment outcomes. And now what we have in the hospital practice, so where we can collaborate, what problems we have in hospitals. Hospitals are completely different institutions, and what is a problem? The medication errors, they are problems. So the prevalence of medication error in Scotland, for example, the Scottish hospital was approximately 7.5%, and approximately 22% of medication errors occur on admission to the hospital. So this is an important point. To make a best history of medication, to make medication reconciliation together, like pharmacists, attending physicians, the nurses, that we are continue with the same medications, which should be sometimes continue, like ACE inhibitors, like statins, for example, and so on. If the patient are entered to the mental health institutions, still, if they have a hyperlipidemia, they still need statins. So that's why it's very important to continue with medications. And then there is a 66% chance for medication errors during VAR transition, and 12 at the time of discharge. So discharge is also important. You know, we learn the patients how to take medications. We should then prescribe prescriptions to the patients and to write a discharge letter. And at the end of the day, we should learn the patients how to take medications, which medications were discontinued, why were discontinued, what is with the prescription for the future, what will be for the next step, and so on. So it's very complicated story, and that's why many medication error occur at those levels. And very interesting that in French, the prospective observational study, 30% of patients had at least one intended medication discrepancy, and the most were medication errors. So most were omissions, and potential severity was observed in almost 40% of patients. And in one very specific study done in psychiatric hospital, Oliveira and co-authors, they reported positive result of hospital pharmacist-led medication reconciliation in acute psychiatric ward. and collaboration with psychiatrists was needed in 74% of patients, and 360 discrepancies required clarification with psychiatrists. So more than 80% drug omission, 5% drug substitution, 7% dose change, and 3% dosage frequency change. So it means that medication errors are very, very frequent, and the issues are here. So that's why we should collaborate in a real clinical practice and solve together the problems. So the strategies are needed, like medication reconciliation after admission, before discharge, after discharge, and including different healthcare professionals like clinical pharmacists. And now, in the United States, they provide, I would say, one milestone study, which was published in Pharmacotherapy like 20 years ago by Professor Bond from the University of Texas. They included like 1,081 US hospitals, and they checked the impact of clinical pharmacist interventions on the medication errors on occupied bed per year. And they also included mental health institutions. And the highest impact on of clinical pharmacists was where clinical pharmacist was included in the medical round participation. So together with psychiatrists, with the other colleagues, when we go to each patients and to identify medication-related problems, and then usually, such as a practice in my hospital in Slovenia, we go to the separate room and then we discuss what we will do. For example, always I discuss about interactions, about some antipsychotic polypharmacy, about some statins, how to manage also comorbidities with schizophrenia, which is very important, when to add statins, when to add SAC inhibitors, what to do with the beta blockers, and so on. And together we can do better. And the next important issue was associated with the drug admission history. So if pharmacists provided, then it was 51% less medication errors compared to the hospital where clinical pharmacist was not included. So those tasks provided by clinical pharmacists can really improve patients' care in the hospitals. And now, what is the seamless care concept? So this is I would say one huge word over the medication reconciliation. Usually we have patient at home, and then patient they are going to the hospital, and they are leaving hospital again to home. So there are two steps: admission reconciliation at admission, when we check the medications, what was taken at home and what is on the medication list, and then we compare both lists, and then we make a decision. So like clinical pharmacists, we are providing now in Slovenia for 2023 in all hospitals, also in the mental health hospitals. So we select more or less all patients at admission. We provide the best possible medication history from different sources, like we identify the problem, we interview family, we interview diabetologists, for example, when we have the insulins. Then we interview the GPs sometimes when we are not sure. Then we have medication list at home. Then we have some e-prescriptions in the Slovenian database. And then we have some previous patient health records. And from all data, we then provide best possible medication history, and then we compare with the medication chart. So at the time of admission, and then we go to the attending physician, and then we collaborate and we try to fix the problems. Some omit the drugs, we add the drugs then, like the statins sometimes, because the patient with the mental health problems, usually they don't know what they are taking at home. And sometimes they are very depressed. They have a problem with anxiety problems, and it's very difficult to identify medication from them at the time of admission. And that's why it's very important to collaborate with that steps. And then we follow the patients to the discharge. And then when there's a time of discharge, usually physicians, they write discharge paper. And we check discharge paper to the medication chart. And then we make medication reconciliation at the discharge. So before the patient leave the hospital, it is usually the same day, but before, and we still have the patient. Why? Because we can correct something about dosing, for example. We sometimes recommend to to add some filtration, same, and so on to the discharge paper. So we collaborate, and then we provide medication list to the patient, and then the patient usually leave the hospital. So it's a very complicated step, and that's why it's very important that we collaborate at each step to avoid medication errors. And what is in Slovenia? We have a standard operational procedure, which is adopted by the Slovenian government and Slovenia Pharmacy Act. And the clinical pharmacists, we provide seamless care. So it means that first we do best possible medication history in hospital, then we provide medication reconciliation and admission with attending physician, and then we provide medication reconciliation and discharge with the discharge physician, and then we provide personal medication card to each patient before discharge. So we go to the patient with a table, like table form, and explain to the patients all medications, how they should take it. For example, for the like zuclopentixol or ziprasidone, the better example, it's very important that the patient takes ziprasidone by food, for example, and so on. So we make all these recommendations to the patients, and then give a medication card to the patient physically and also to his or her data set. No? So the all GPs and all psychiatrists also and all pharmacists can check immediately with which medication patient was discharged from our hospital the same day or maybe the previous day. And then also we dispense medication for the home stay for 1 month, which is important because usually some pharmacies in Slovenia are closed during the afternoons, or in some places we don't have pharmacists, and that's why it's important that we provide medication for the 1 month, 1 to 3 months. We can do that from this year, and then we can teach the patients and then give medication to the patients. So we admit and discharge well-educated patients. And why pharmacists should do that? It's very clear that according to the studies, medication accuracy increased from 50% to almost 100% where clinical pharmacists provide medication reconciliation. So it's very important that we have pharmacists inside. And this is also a recommendation by WHO to add clinical pharmacists to that process, because we can identify more medication in the process than others. Usually nurses do. In some countries, the nurses take over those processes, but they are not so capable to identify medication-related problems as the pharmacists are. And that's why it's very important that we put clinical pharmacists inside. And what I do in my hospital, for example, first at admission, I go to the patient, I identify problems, then I check the e-prescribing, all different previous charts. Sometimes I call my colleagues, diabetologists or the GPs, especially when I have insulins, because sometimes patients, they do not know the dosing of the insulins. They are not very sure about the dosing. They are not sure about the statins, which statins was stopped, which was added. So it's a lot of mixture. So it's like a salad sometimes. And that's why it's important to provide smooth transition of the patient. And then I provide medication review, and then I go to attending psychiatrist, and then we make medication reconciliation. And what we do at the discharge, so we have discharge paper, and then we have the medication list. So each medication, dosing, then indication and how to take medication, and also which medication were discontinued. This is also very important to explain the patients all the changes. And then we also take the medications for the 1 month, and with the medication we go to the patient and then explain to the patient all scenarios and the all changes, and sometimes also relatives, because especially psychogeriatric patients, they are not very capable to accept all of that information, and sometimes you know the son or maybe the daughter, they are coming to pick up their parents, and that's why we also teach them, because they prepare medications for their parents. And how it looks like, it is standardized in Slovenia, so all hospitals, also mental health hospital and the general hospitals, we are providing the same medication personal card form, which was established by the pharmacists and Ministry of Health of Slovenia. And first, we write medications, then the dosing, then how to take medications, and which medications were discontinued. This is important, and some over-the-counter medications, and some other recommendations to the patients or to the GP, because the patients usually they go then to the GP in the 1 to 2 weeks, and that is important that we transit information to the GP. Here's one very similar case from one of my workplace. In the middle is a patient's therapy in the hospital at admission. So patient was treated with amlodipine for hypertension, then with pantoprazole 40 milligrams, losartan for hypertension, furosemide, escitalopram for depression, and trazodone was added for insomnia. But when I provided best medication history, I checked that patient was treated yesterday with paracetamol, ibuprofen, and naproxen and lidocaine patch. But patient was very depressed, and the patient was not capable to report all medication to my colleague psychiatrist. And what was very interesting, that the patient reported that he was treated with escitalopram, which was true, but before 8 months. But before 1 month, patient was treated with sertraline because his GP switched escitalopram to sertraline. So when I observed that, then I suggest to my colleague psychiatrist to go back from escitalopram to sertraline and to add some medication, because I identify low back pain in the patient. So I suggested to add at least paracetamol and ibuprofen to the patient, which was accepted by my colleague psychiatrist. And at the end, here is the patient therapy discharge. So patient was treated with sertraline then, and then some pain medications. So it's very important that we provide medication reconciliations to be sure which medication should be used in a patient in the hospitals. And the next study, we also provided some studies where we put inside the hospital team clinical pharmacist. So usually we are going to each patient step by step, like psychiatrists, then nurses, and then we also added clinical pharmacists around the patients. Why? Because we wanted to check if there is an impact on the total number of medication-related problems. So if we can do better together. And in that study also published in scientific reports 2 years ago, we included 75 different VART rounds, including clinical pharmacists, and approximately 4.2 recommendations were provided by each VART rounds, and acceptance rate was approximately 95% by psychiatrists. And very important that the most interventions were associated with unnecessary treatment. I mean, irrational polypharmacy. Sometimes patients were treated like with 2 or 3 different antihypertensive medications, which was not necessary. For example, and the pharmacists recognize that when we provide VART rounds. So that's why it's very necessary that we as a team go to the patients and identify medication-related problems. And when we are going a little bit further to the intervention classification, if we divide to the potential and the real problems, the most problems were associated with the potential problems, but follow very, very closely with the real problems. It means that a pharmacist, if is with a team, can recognize a lot of the real problems which are not recognized by the others. No, so it's important that together we recognize more problems as alone. And on which wards recommendations were provided? All wards in psychiatric hospital, like closed wards, like for example, ward for addiction treatment, open wards, daily hospital, and so on. And then when we are going through some different specific interventions, first I would like to go through antibiotics. In the most cases, clinical pharmacists recommended very narrow antibiotic for urinary tract infection, lower urinary tract infection, which is according to the guidelines. Like, for example, nitrofurantoin was suggested instead of ciprofloxacin, which is not recommended, especially in patients with mental health problems. Then amoxicillin was suggested instead of moxifloxacin, for example, and the most recommendations were accepted by psychiatrists. And then we are going to the antipsychotic therapy. Then it's very important that the number of patients who were being treated with antipsychotic polypharmacy dropped significantly. And there were many recommendations in the dose adjustment. I don't go now through very in details, but you can read the paper. But it's very important that also on antipsychotics we can do the things, some things together. And now one study which was done in the United States at the admission to the psychiatric hospitals, where they included clinical pharmacists in the patient with antipsychotic polypharmacy, and clinical pharmacists provided recommendations to the psychiatrists within the hospitals. After the study, the number of patients who were being treated with 3 antipsychotics concomitantly or 2 antipsychotics concomitantly were dropped significantly. So it's important now that we should make some recommendations. We can provide some services to improve antipsychotic treatment, and especially to minimize number of patients treated with antipsychotic polypharmacy, which is not recommended only after clozapine monotherapy according to the guidelines. And now, what's next? In my country, Slovenia, we have psychogeriatric teams, and the clinical pharmacist is a necessary part of the psychogeriatric team, usually on more than 100 beds. We have at least 1 psychiatrist, at least half clinical pharmacists. Then we have also psychologists, nurses, and some other healthcare professionals. And we provide the common treatment plan, which is necessary in Slovenia. So each healthcare professional provides treatment plan, and then every week we revise treatment plans, and we check if what outcomes are. We measure outcomes, and then if we reach or if we don't reach outcomes, and then we provide some recommendations. So this is a simple form. For example, like psychiatry, clinical pharmacist, and the nurse first at the admission, we identify problems and the risk factors. Then we write expected outcomes, the activities, how we can provide expected outcomes, like medication review, like the seamless care, for example, and then of course the discharge plan and the outcomes. So it's important that in all Slovenian psychiatric hospitals we have very similar forms, and then we can also compare the results to each other, which was not possible in the past. And now I'm also included in European Association of Clinical Pharmacists. We had a congress now in Aberdeen in Scotland in the last week. We also wrote a very interesting commentary position paper where we can improve mental health treatment. And what was very clear, that in many countries the clinical pharmacists can help to address these gaps, but they are still not part of the mental health teams, except, for example, UK, especially Scotland, England, then Wales, Northern Ireland, and also Slovenia, which was found in our review. And now, my dear colleagues, here is my summary. So the clinical pharmacist is a crucial healthcare team member in the patient with a mental health disorder. So the roles and responsibilities are different in different countries. This is very clear. We have many countries in which we don't have clinical pharmacists either. We have some countries where we are part of the team of the daily round, so we provide the reviews, we make the seamless care, check the medication admission and discharge, and so on. And we collaborate. It can lead to lower number of PIMS, lower number of medications and drug-drug interactions, and it can improve the treatment guidelines adherence. So I'm very close to my end. I would like to say that we should look for the win-win situation, and we can help psychiatrists, and what is good for the patients is good for us. So my dear colleagues, thank you very much for the invitation. I would like to hear the questions from the audience.
I think Daria, but I can start with a question then. My question would be that very often we do not have one system or one computer system. I think it might be easier in different countries. We really struggle to get information, so we have different. I sometimes work in different areas in Scotland, and everywhere it's a different computer system. Everywhere it's a different concept. And I'm struggling with that, sometimes getting the information, and sometimes I realize even the patients are not the best of informants. So that's one of my questions. So how can you just get the information from the patient to the pharmacist, to the doctor, and return? That's a computer system. And if I may ask another question, is we very often, we had these recommendations where I just was confronted with the wish of a pharmacist who said, whatever we start aripiprazole with, let's say 2.5 milligrams because of possible side effects. So the question sometimes is, we have this recommendation starting lower in the elderly, but just to avoid side effects. But is there any assumption that lower works better or equivalent to higher in other people? So if you take lower, can you say this works as well as higher in other patients groups or younger patient groups?
Yeah, I think it's very important. The first question about the data about patients. Everywhere we have the same problems, and especially in my country, we still have some some paper charts. Also in some hospitals, in some hospitals we have electronic charts. What we do as a pharmacist, first of all, we identify medications in the home medications. So we check the GP's prescriptions, then we talk with the GPs and also with some other specialists, like the diabetologists, for example. And then we also check the previous discharge papers. And then we go to the patients and ask the patients about medications. And then at the end of the day, we provide like medication review. And then we go to the ward and then we check the medications on the ward. And then we check with the attending psychiatrist, for example, or infectologist, whatever, because in all hospitals we provide that, the real medication which should be on the chart. So this is about the admission. It is a big issue. And sometimes some of medications are also not included in the e-prescribing system, as is the case in my country. That's why it's very important to collaborate with GP, because the GP usually they have all medication lists for the patients, and sometimes we recognize that, for example, patients should be treated with statin, but nobody didn't add statin in the hospital, and the patient didn't say that's high, I should have statin. And the same situation with the vitamin B, for example, and some other medications like biphosphonates and so on. And the similar scenarios are in some general hospitals when sometimes they stop with psychiatric medication, psychotropics, because nobody didn't ask the patients, and the patient did not say that. And that is a big problem, because we can have an impact on the adherence of the patients. So that's why it's important to make a comprehensive review at a special admission and also at the discharge. Sometimes what we recognize at the discharge is that, for example, psychiatrists write discharge letter, and discharge letter there is dosing like aripiprazole like 5 milligrams, but on the chart was 10 milligrams. And then when we check that, we talk with a psychiatrist, and then sometimes we recognize some mistakes, and then we can improve the discharge letter together. So this is another issue. And about dosing, yes, I think the first problem is we have a guidelines, and many of physicians and many of pharmacists, especially pharmacists, they follow very strict the guidelines. But we know in the clinical practice sometimes we should make a quite faster titration. Why? Because then we can reach the steady state quite faster, and we can expect an effect faster as in a slow titration. So it's very clear. But there's always risk of the side effect, no? But for the antidepressants, for example, we have very poor data that very higher doses of antidepressants are more effective than the normal doses, no? And the same story with these antipsychotics, especially with the aripiprazole. We don't have good data that the dosing after, for example, 15 milligrams is more effective like 30 milligrams. So that's why I think it's important when we have time to go very slow, especially in elderly patients, and when we have the anticholinergic medications. When we don't have anticholinergic medications, like for example, aripiprazole is not anticholinergic medication, it's a bit sedative medication, then we can go a little bit faster. Now, this is according to my clinical experience in the psychiatric hospital and the nursing home settings, when we sometimes go a little bit faster, like seen in the guidelines or the summary of the medical product characteristics.
Okay, is there any other questions? I don't know. So Daria Smenova is just, or Christoph. If not, I think it was a very good talk, and thanks a lot for this talk. And yeah, I think I missed meeting you in Aberdeen, so that's very sad. And next time, if you come to Scotland, you have to promise to come here. Right.